This is Dan. I'd like to thank Dr. Goltekin for taking the time to help us out here with our neuropathology for the month of October. We have actually 4 extremely interesting cases, so this should be very educational for people. So I'm just going to pick on one resident per case just to make things go a little smoother. So for the first case, Vignesh, I'm going to call on you. So this is a 53-year-old gentleman who presented with worsening confusion, aphasia, and hemiparesis. Was afebrile. He has a history of sickle cell trait, a right pica stroke, diabetes, hepatitis, and hypertension. His social history was notable for swimming in freshwater canals once a month, and most recently he swam several days ago, and he also frequent cocaine use. So on physical exam, he was confused, oriented to name only. He was obtunded, basically saying yes to every question. He had face was intact, was symmetric. He was very weak on the right side, 0s to 1s on the right hemibody, and left side was at least hemigravity or anti-gravity, moving spontaneously, and moved his right side or his left side to noxious stim and wasn't moving his right side to noxious stimulus. So Vignesh, any other tests, labs, imaging that you'd like to know?
In terms of labs, I think we could consider getting like ESR CRP, just with the history of like swimming in the freshwater canal, just like if we were worried about infection. And then I guess, we could start with that. And then, yeah.
Okay. So ESR and CRP were elevated. Normal echo, blood cultures, UA and chest X-ray were normal, missing teeth but no recent dental work, HIV negative, elevated white count with 78% neutrophils, and then an pretty elevated ESR and CRP. So I guess just early thoughts, you mentioned infectious. Anytime you hear the word like confused or obtunded, any other like things that pop into mind?
For sure, yeah. Always thinking about hydro, either from like, an obstructive mass, that would be causing some sort of obstructive hydrocephalus. So I guess the etiology could be either infectious or, from a tumor or some other entity causing hydrocephalus.
Sure, definitely. Those are all great thoughts. It's always good to start organizing your thoughts before you can see the imaging. So this is a CT. Any comments about the CT?
Looks like there's a hypodense lesion sort of in the left sort of basal ganglia internal capsule area. That doesn't look it's he's got temporal tips, but I think that may be a consequence of
Yeah, sorry, I don't know if it's my internet connection or your internet connection, but I heard left basal ganglia thalamus, temporal tip. So this guy's 53, so you would not expect temporal horns for him. He does have some atrophy, probably greater than what you would expect for his age, so it could be sort of ex vacuo, but definitely is prominent temporal tips. And then on the MRI, what do you see?
He's got a ring enhancing. I guess let's see. The top is on contrast, and it looks like the top is contrasted. So it looks like he's got a contrast enhancing or ring enhancing lesion, sort of in the left basal ganglia thalamus area. That let's see, has like a significant component of I guess edema surrounding it on the flare sequence. And then I'd be to see what I guess like if it restricts on diffusion as well.
Yeah, well, this is the diffusion scan, but whenever you see like a rim enhancing lesion like this, what are like the 3 things that you'll kind of automatically
For sure.
say?
So
like what's in the differential?
1 would be high grade glioma, 2 would be lymphoma, 3 would be some sort of infectious process.
And there's also another one, metastasis. And
Oh, gotcha. Yeah.
how do you distinguish between high-grade glioma, metastasis, and abscess based on like the irregularity and thickness of the enhancement?
The infection would have quite a bit of irregularity along the ring, with ring enhancement, and then you also have diffusion restriction. Metastasis is more, I guess, like common at the gray-white junction, and then high-grade glioma would be, I guess, it would have like some cystic components. There would be like other areas of enhancement apart from like the ring as well, I think, and then it would be sort of, it would be found sort of, like this would be an area where a high-grade glioma could be found as well.
Yeah, that's all true. And I also like to organize how what the differential is sort of on a spectrum. So it's a spectrum based from like least, or let's say most to least irregular rim, and most to least thick of the rims. So the most irregular and thickest rim is high-grade glioma. The least thick and the most regular, like most spherical rim is actually abscess, and then metastasis is in the middle.
Mm.
Okay. That's like a Dr. Heroes pearl. As you mentioned, it restricts on diffusion. What does that suggest to you?
So likely, I would be thinking abscess in this patient.
Do any tumors restrict on diffusion?
I guess like epidermoids, right?
Yeah, that's
Sure, yeah.
right. So hypercellular tumors restrict on diffusion. So you mentioned epidermoids, so they follow CSF on all sequences except for diffusion where they restrict. Any hypercellular tumors restrict. So like lymphoma restricts. Some GBMs restrict if they're hypercellular. So we talked about this large cystic lesion of the left thalamus, rim enhancing with restricted diffusion. So
epidermoid, by the way, did you say epidermoid is hypercellular?
Sorry, epidermoid is not hypercellular, but it does restrict diffusion. Sorry.
Yeah, interesting. It's almost like a cyst, with keratin. So it's not really cells. Only the cyst lining has some squamous epithelium, but the center is just full of, creamy keratin debris. So just let it known that it's not a hypercellular. It has nothing to do with the cellularity of lymphoma. It's in the opposite ends of the spectrum.
Okay. Yeah. Thank you, Dr. Gultigan. So we kind of went over the differential already. Basically, infectious, thalamic glioma, CNS lymphoma.
Is demyelination in the differential?
Yeah, I mean, I think that, based on the imaging alone, you could think about tumefactive multiple sclerosis. The only reason that that's lower in the differential for me is sort of the mass effects and the kind of infectious picture, and also the kind of rapid onset of the symptoms. For me at least, makes me think a little bit less about it. But yeah, I mean, tumefactive multiple sclerosis could look. I mean, often it looks like this, but just the enhancement is like not a complete ring.
Mm-hmm. And that's what it does. It's kind of a semi-lunar sign. I think that the open end is towards the cortex in tumefactive MS. You see what I'm saying? It's like a C-shaped enhancement with the open end towards the outside, towards the peripheries. And you can have some edema in tumefactive MS sometimes. So it is low in the differential in terms of clinical presentation, and I think other parameters. But just pure imaging alone, I guess T1, T2 alone, it may be difficult to rule out. But just wanted to mention, not at the top. Okay, thank you.
Absolutely, that's definitely on the differential. So he was taken to surgery for EVD placements. He had a left-sided craniotomy for interhemispheric approach for washout of the cyst and drainage. After the washout and antibiotic irrigation, they penetrated the cyst into the ventricle to allow for better antibiotic penetration. And then they did a septostomy to allow the ventricular system to communicate with itself. And then Dr. Goltikin, here are your slides.
Yeah, so this essentially was a cerebritis / abscess picture microscopically. What you see here is a lot of polymorphonucleoleucocytes, these very tiny segmented looking cells, like that and others. There's a lot of like tiny little ant-like, cells or nuclei are essentially infiltrating neutrophils. And in between, there is macrophages, there is some endothelial hypertrophy that is reacting blood vessels, even blood vessel necrosis. So it was an infectious picture. And next slide. So they told us, do you have a next slide? Yeah, they told us that, this could be because of the freshwater swimming episodes, it could be a Naegleria, and we did look for Naegleria-like organisms, and I found a couple of candidates. You see one in the center, top center, that round blue big blob. But it was a tentative, of course, statement on my part. I wasn't sure. It's difficult to be sure in amoeba species, just based on pure histology. We had an autopsy case before in Jackson, so I kind of know, how they look from a couple of cases in my experience, but in this case, I wasn't really sure. And most of the, actually all of the stains for microorganisms remained essentially negative.
I'm a spine fellow.
Excuse me? Hello? Okay. Yeah, so they sent the tissue, we sent the tissue to Centers for Disease Control. And the report, that there are two reports, but the second report did not come to us yet. The first one says, essentially negative with the staining of various agents, including free-living amoebas like Naegleria, Balamuthia, Acanthamoeba, and selected gram-negative bacteria. This is immunohistochemical specific staining that only CDC has. Now, they detected something molecularly, which is very interesting. It is a Fusobacterium nucleatum. Does anybody know what this is? Fusobacterium species? No. So the Fusobacterium nucleatum is a commensal organism. Essentially, there's a ton of it in normal people's mouth. It's an oral bacterium species. So sometimes it can be pathogenic. And I looked it up. Brain abscess is an extremely rarely reported association with the Fusobacterium nucleatum. You could look this up, and when the second report comes from CDC, they still say there's no amoeba, etc., and they repeatedly say Fusobacterium nucleatum. This may be a reportable case. Okay, so with the evidence that we have right now, it looks like a bacterial abscess, essentially. Okay.
Okay.
But of course, the suspicion of Naegleria clinically was made it the most. I get the history of freshwater swimming made it the most likely thing. I don't know if the guy had sinusitis, because those are the ones that you have to consider with the Fusobacterium, things in the head and neck that make him, susceptible to a brain abscess, ear, inner ear, sinus, etc., etc. So anyway, I'll leave you to continue.
So yeah, I mean, sort of inconclusive at this point. I just wanted to discuss Naegleria because it's so rare. I don't know when we'll have the next opportunity to discuss it. So basically, Naegleria is the pathogen that causes the disease primary amoebic meningoencephalitis, the 97% mortality rate, and patients typically die from increased ICP and cerebral edema, usually with a very delayed diagnosis. It's rare, only 138 known cases and only 5 documented survivors, which is pretty amazing. And the good news is that it's thermophilic. It likes warm water, and because waters are getting warmer, it may become more common. It's the only amoeba that causes CNS infections, which is kind of interesting, and it invades through the nasal olfactory mucosa. Typically, the disease happens within 5 days of swimming in warm fresh water. One way to diagnose it is to do a lumbar puncture, and then you have to do a wet prep, and you may be able to see motile trophozoites. So this is a wet prep with a Gimsa stain, and this is showing a trophozoite. This is showing the life cycle of Naegleria. So it starts as a cyst that lives in the water, eventually becomes a trophozoite and can become flagellated, and then people swimming pick up either the trophozoite or the flagellated form, and then penetrates into the brain through the nasal mucosa. And then on the right, I just think this is an amazing electron microscopic picture. Basically, Naegleria eats bacteria like E. coli, and it has these little food cups. They're called food cups, and like the bacteria goes into this little food cup. So kind of like this microscopic monster type thing. Pretty cool. Other CNS parasitic infections, typically the only ones that neurosurgeons may have to biopsy are these first 4: neurocyst or stricosis, toxoplasmosis, echinococcus, and Naegleria fowleri. Other ones, diagnosis more from blood tests or for lumbar puncture. Treatment is sort of evolving because it's so rare, but there's a breast cancer and anti-leishmania drug called miltefosine, which has been showing some promise, and some reports have shown it's used combined with fluconazole and rifampin, but it's very important, at least from neurosurgeons' point of view, to manage the ICPs. And you can also call the CDC for guidance because they have the most up-to-date treatment recommendations.
Yeah, before we go to the second question, I realized that this was an abscess, right? And what you're saying is that the Naegleria causes a diffuse meningoencephalitis most commonly. You see what I'm saying?
True. Yeah.
So abscess, differential diagnosis is not immediately an amoeba in the brain. So, and these cases are very, very severe and almost always fatal and cause a lot of damage early on, and they are diffuse. So when I saw that your title is neurosurgically was cyst capsule, I said, cyst capsule, it probably is not an amoeba abscess. So you see what I'm saying? So, but anyway, it's a very difficult and interesting case. Thank you.
Wow, thank you.
I have a quick question. Was it intentional to communicate with the ventricular system?
It did. I mean, it's right next to the ventricles.
Good point.
And,
So is this
obviously
specific from this pathology? Because usually we avoid, when we drain lesions like this, we try not to communicate, not to spread into the CSF. I don't know. Is this specific from this pathogen?
I wasn't in the case, but I mean, the op note says that they wanted, I mean, I agree, you don't want to get ventriculitis and cause ventricular spread, but I guess they were concerned, they thought that if they irrigated it copiously with antibiotics and then penetrated into the ventricular system, they thought that the antibiotic penetration would be better.
What happened to the patient? Do you know?
I think he's still alive, but still in a critical condition. EVD was taken out. I think he's still in the MICU. So this is like a month later, more than a month later.
Okay.
Challenging case. The next case is Eva on.
I think she's on vacation this week.
Oh, sorry about that. Okay. Damien. Sorry, I can't see who's on. Can someone volunteer?
Look, there you go. Go to presentation
Is
mode.
Silva on?
Hey, Danny, I'm here.
Hey, okay, great. Thanks, Silva. Okay, this is a 25-year-old Brazilian female with a 4-month history of low back pain, 2-month history of difficulty walking due to pain, no saddle anesthesia or bowel bladder incontinence, no IV drug use or any medical conditions. Only medical history is that she had LP proven meningitis at age 5, afebrile, and some slight numbness in the medial aspect of her thighs and pain in the low back when walking. ANO times 3, 5 out of 5 strength in the upper extremities and sort of 4+ pain limited strength in the bilateral hamstrings, but otherwise full strength, and has some slightly diminished sensation along the medial thighs. So this is some of her imaging. I'll let you take a look at this for a second. I'll go to the next slide that has more imaging. Okay, can you kind of describe what you see?
Yeah, so it looks like from like L3, even up to L2 to L5, she's got, first of all, some bony erosion, looks like a mottled appearance, both like anteriorly and posteriorly. She's got posterior compression of the thecal sac. Looks like some, looks like some edema, again, in the posterior elements, and then kind of like posterior compression at worse at L3 and L4. So yeah, I would be concerned for some sort of infectious process, especially considering her prior history of meningitis, but she does have a reassuring exam.
Mm-hmm. Yeah, her meningitis was like 20 years ago. So it's definitely, I mean, definitely something to think about. It was a while ago. And then on this, it's a little hard to tell, but this is a contrast scan, and this is a diffusion scan.
So yeah, given the restricted diffusion, be concerned for abscess. It looks like I don't see anything particularly enhancing there. But yeah, I'd be concerned for some sort of abscess.
I think they call this area enhancing. So I would say it's an enhancing, epidural mass that restricts diffusion. Anything else that it could be beyond the differential?
You just quickly add that the presentation was a little bit slow. She had back pain, no fever.
I think it's odd to have an abscess at this location without any trauma or surgery or immunosuppression in a 25-year-old, otherwise healthy woman.
I mean, I guess it could be a malignancy given that kind of like slow, gradual onset with restricted diffusion. Again, going back to the prior conversation of the differential, I guess. I mean, I've never seen it in this region, but like an epidermoid or other type of malignancy that would restrict, but I'm not sure.
And so would you say it's for the tumors, would it be intramedullary, extramedullary, intradural, or extradural?
It looks all extradural. It looks like the compression is all like epidural posteriorly.
So what are two things that are like spine tumors that are extradural?
You could consider meningioma. You could have schwannoma, and
Those are actually typically intradural. So extradural, I mean, two things that you can always say are metastases and primary bone tumors. And because it's restricting diffusion, one other possibility is lymphoma. She had pan neuroaxis MRIs, which were all negative. Basically, all of her other lab tests were pretty unremarkable. Talked about the differential diagnosis. So she underwent an L2 to L5 hemilaminotomy and tumor resection from the epidural space. And these were her pathologic findings. Dr. Goldtegan.
Yeah, so the first biopsy was biopsy of the soft tissue here. The pink part that you see is essentially a paraspinal muscle, and the blue is the infiltrating, small round nuclei. Okay, and from, of course, low power, you can surmise that the cells are smallish, round, and it does look like either inflammation or lymphoma. Next slide. Okay, then they stained it. We gave it to HemePath immediately because we thought that this was going to be a ultimately a lymphoma, and they want to work those up themselves because of the systemic treatment. So in this first one, that was from September 14, I believe, they were not sure. They said atypical cellular infiltrate. There are some atypical lymphoid cells, but they couldn't really commit themselves to this being lymphoma by immunohistochemistry. But it looks here that the CD20 is really homogeneously positive in every single cell. And there is a very high suspicion that this should be a B-cell lymphoma. Next one. So this was the first biopsy. The second biopsy was, I think, easier to diagnose. It does show a lymphoid infiltration with atypical nuclei. Next. Next slide, please. Okay. And again, it is, strongly, decisively positive with B cells. I mean, again, every cell here is a B cell. We do T cell markers, B cell markers, and some other types of markers to see if, to decide if this is a neoplastic lymphoproliferative disorder. And one of the very first steps is to see the ratio of the B cells to T cells. If it's like 100% B cells like this, it's highly likely that this is going to be a B cell clonal proliferation. That's why I'm showing you this next. And oopsie, this is striking. This is a Ki67 index. It's almost like 100%, right? So this is what lymphomas do. And you can even use Ki67 to sometimes, support lymphoma versus inflammation, because in inflammation, you will never see 85, 90% Ki67 like this. You will see 5, 10% maybe. So it's an additional indirect supporting stain. But of course, in this case, they did BCL2, BCL6, PAX5, all those lymphoma markers, and decided in the end that this was diffuse large B-cell lymphoma with a high proliferative rate of 85 to 90%. Okay, that's it. So it was a lymphoma, germinal center type.
Okay. So, there's two kind of broad categories of CNS lymphoma. There's secondary CNS lymphoma, which is basically metastatic spread of systemic lymphoma to the brain, versus primary CNS lymphoma, which is what this is, which is a rare malignant primary CNS form of non-Hodgkin's lymphoma, comprising 0.85 to 2% of all primary brain tumors, and then may occasionally metastasize outside of the CNS. So there's different subtypes of primary CNS lymphoma. The majority of them are diffuse large B-cell lymphomas of the CNS, but they can also be categorized below. Other broad categories are immunodeficiency-associated CNS lymphomas, intravascular large B-cell lymphomas, low-grade B-cell lymphomas, T-cell and NK/T-cell lymphomas, and anaplastic large cell lymphomas. In terms of epidemiology, they are the third most common malignant primary brain tumor behind GBM and diffuse astrocytoma. They've increased in age, in commonality over the last several years, more common in men. Median age diagnosis is 52, although in immunocompromised patients it's 34, so this patient was pretty young to have this diagnosis. And most commonly, they're found in the frontal lobes, the deep nuclei, periventricular regions, and then finally cerebellum. Spinal epidural lymphomas like this one are very rare. Rare presentations of non-Hodgkin's lymphoma occurring in only 0.1 to 6.5% of non-Hodgkin's lymphoma. So this is a pretty rare case.
So the primary, this is a primary CNS lymphoma?
I believe so. Yeah.
Because it's an epidural soft tissue space. I'm just, being the devil's advocate. So is this considered the CNS location?
I mean, it's technically outside of the dura, but
Yeah.
I mean, I've just the reports that I had read kind of classified it there, but I guess it could be classified as, extra CNS.
I mean, if you think about drug therapy, they will consider this as a non-CNS because there is no blood-brain barrier when you think about chemotherapy, right? Unless it goes into the, so from a technical therapeutic point of view, it's an extradural location. Anyway, I mean, it's a minor point, but something to think about. Okay.
That's a very good point. Other conditions that increase the risk of getting CNS lymphoma, autoimmune diseases, lupus, Sjogren's syndrome, rheumatoid arthritis, immunosuppression like HIV, pharmacologic immunosuppression, like if you're an organ transplant recipient. Also older people, possibly because their immune system is compromised, and an Epstein-Barr virus is very common in a lot of these immunosuppression-related lymphoma cases, especially HIV-related cases. On pathology, it's characterized by perivascular growth of large atypical lymphoid cells. With continued proliferation, the distribution becomes more diffuse and sheet-like. Apoptosis and necrosis are prominent, and diffuse large B-cell lymphoma is the most common. And then I just pointed this out because people often get a lumbar puncture for cytology to look for malignant cells to try to obviate the need for surgery, because it's very radiosensitive and chemotherapy sensitive tumor. But we found that only 7.4 cases was CSF cytology enough to obviate the need for surgery. So it's pretty bad test. As I mentioned, radiation therapy, methotrexate chemotherapy, because this is more for, primary CNS lymphoma, but Ommaya reservoir placement for intraventricular methotrexate. And, typically if you're able to biopsy this and prove that it's lymphoma, then you don't need to do a whole resection because it's chemo and radiation sensitive, unless it's because of compression causing neurological compromise. The prognosis is very poor. It's actually a little bit worse than glioblastoma. Median survival is 10 months with treatment. Okay. Is Mike Cater on? Is Kat on? Okay, so I'll just go through this. This is a 53-year-old right-handed male, presents with progressive thoracic pain, worse when lifting heavy objects, denies lower extremity weakness, denies numbness, no bowel bladder incontinence, nothing really that interesting on his past medical exam, history, neuro intact on physical exam. This is his CT, and this is his MRI. So yeah, T2 hyperintensity. Vertebral body has these sort of vertical striations here. You can see that it's sort of involving the foramen and kind of pressing on the spinal cord. It's also going, entering into the mediastinum here. It's avidly enhancing with gadolinium enhancements. As you can see here, it sort of has these little dots in the bone, the vertebral body that's associated with it. They got a PET scan, which I guess because of the intensity of it, they believed it was benign rather than malignant. So differential diagnosis, I mean, it looks sort of like an extradural, extramedullary mass. So you think about primary bone tumors and metastases. I think with these sort of two things that kind of, these sort of vertical striations and dots are kind of characteristic of vertebral hemangiomas, which is a benign primary bone tumor, which typically are incidental findings, but can occasionally cause either pain or problems due to very large size. So differential is relatively broad. So he underwent the plan was to do a 2-stage surgery. First, he underwent a T2 to 3 decompressive laminectomy and right side foraminotomy, fascectomy with T1 to T3 posterior segmental instrumentation. And then the plan was to obtain a diagnosis, decompress, and then stabilize the spine. And then the remainder of the residual tumor would be resected by thoracic surgery, and eventually underwent a thoracotomy to resect the remainder of the lesion.
As you said, the phlowoids, I guess you could call them, are characteristic of a vascular, right, component to the tumor. And indeed, what we see here is a bunch of thin-walled, dilated blood vessels interspersed by connective tissue. So this is the quintessential hemangioma. No malignant, nuclei. There is no arterial component, and it's a vertebral hemangioma. And this is high power view. You see the same thing. The orange stuff is blood, surrounded by the very thin layer of endothelium. The purplish stuff in between is the collagen of the connective tissue. And you can see 1, 2, 3, 4, 5, 6 blood vessels here. And the nuclei have no atypia. I mean, you always have to keep in mind angiosarcomas and other types of sarcomas, or vascular rich osteosarcomas that are the realm of the bone and soft tissue pathology. But in this case, luckily, it wasn't any of those. It was just a hemangioma.
Thanks, Dan. Can you go back to the MRI scan?
Mm-hmm.
So yeah, when we saw this, we weren't sure exactly what it was. Clearly the changes in the vertebral body are extremely suggestive of vertebral hemangioma. But you can have an exophytic component of it. I've never seen this large of an exophytic component personally. It was extending into the chest. And so we did the posterior knowing that we were going to do stage 1, stage 2. It was extremely vascular. And then just the only point is that when you do surgery for these, it's always important to get an angiogram. In this particular case, we did the angiogram between stage 1 and stage 2. We were able to control the bleeding intraoperatively. but it is extremely helpful to get an angioembo. And I think Dr. Peterson, if I remember correctly, did that between stage 1 and stage 2. And even despite that, it was very, very vascular for Dr. Nguyen to remove the thoracic component of it. If no embolization is done and they're as big as this, it's not uncommon to hear that, you know, someone takes a bite of the tumor and they lose 2 to 3 liters of blood. I don't know if you were looking at the part 1 or part 2 tumor, but if the part 2 tumor, I'm sure you'd see embolic material within there.
And unfortunately, I don't have pictures of the part 2 tumor. But yeah, I believe Dr. Peterson did an angiogram.
Yeah, I didn't see it, but at least it's not in the report. Dr. Rosenberg looked at this one. But it's visible when it's there. It's blackish material that we can identify.
So vertebral hemangiomas are the most common primary spine tumor, and they're completely benign. They're relatively common. Up to a third of the population has them, and they're almost always incidental findings that you don't have to treat or follow. Some of them about 1% become symptomatic, mostly either pain, or if they become very large, they could produce neurological deficits. You know, in imaging, I'll go into imaging in a second. So the malignant degeneration does not occur. And what happens is that mature thin-walled blood vessels of varying sizes replace normal bone marrow, producing hypertrophic sclerotic bony trabeculations that are oriented in a rostral caudal direction, which is why they have those vertical striations. And they can occur in 2 forms: cavernous, which is venous, or capillary, although there's no prognostic significance between these 2 categories. As I mentioned, typically they're incidental and asymptomatic, but they can cause pain or neurological compression. Here's a great picture of the vertical striations, which you can see on a CT or an X-ray. Some people call this the corduroy sign. Another great picture here. And then on an axial, they call it the polka dot sign. So this is very characteristic of vertebral hemangioma. On MRI, this isn't super helpful because basically they can be either hyper or hypo intense on T1 and T2. But often they contrast enhance because of the high vascularity. Treatment. So asymptomatic hemangiomas don't need treatment, don't need follow-up. If they present pain or neurological deficit, some people do vertebroplasties for pain. If you're going to operate because they're large and causing neurological deficits, as Dr. Levy mentioned, it's very important to get an angiogram and try to embolize these as they're extremely vascular before surgery. And we actually looked at our series of aggressive vertebral hemangiomas and found that it's safe to do so, to embolize and then do surgery. Okay, and the last case is James on?
Do you have your app ready? No, we don't. I don't have app.
Hey, Dan, I'm here.
Thank you.
Hey, James. Thanks for volunteering. This is the last case. This is a 58-year-old female. History of autoimmune limbic encephalitis with CV2 antibodies, diagnosed 1 year ago. Polysubstance abuse, hepatitis B, and psychiatric disorder. So this was her MRI from 1 year ago, which led to the diagnosis of her autoimmune encephalitis. So do you notice anything kind of striking about this MRI?
So we're looking at an axial flare sequence of the brain. On the mesial structures in the right temporal lobe, there's some flare changes. And in comparison to the other side, which doesn't have any flare changes, it seems to be a bit more full, that gyrus.
Yeah, exactly. So 1 year later, she was in the psychiatric hospital and had new onset seizures. So she was transferred back to Jackson. She was awake, alert, and non-somnolent, moving extremities spontaneously, had a non-focal exam, but was not very cooperative with her neurological exam. This is her CT, and then this is her MRI that she had. And can you tell us what you see in the MRI?
So the top panel is an axial, coronal, and sagittal MRI of the brain with contrast. It seems as if there's a enhancing lesion in, can't tell exactly where the hand knob is from that, but it looks like it's in the left frontal lobe. It's homogeneously enhancing, and there's surrounding edema, which is confirmed on the flare and T2 in the bottom sequences. And it looks like it's actually, it's anterior to, anterior to the hand knob on that bottom right sequence, the flare, I think.
So the bottom right is actually diffusion.
Oh, diffusion. Oh, okay. It looks like it slightly restricts on diffusion, and it's some pretty significant edema around it.
Mm-hmm. And any differential based on these images?
Differential would be, I think if I'm not mistaken, she had a history of polysubstance abuse and immunosuppression, if I'm not mistaken. With that diffusion restriction, I would consider, I would have to consider an abscess in that area. The history, I think, if I'm not mistaken, also of lymphoma, if I'm not mistaken. It does seem like it could potentially be, like, I don't know, lymphoma, like a dural-based met, because on the coronal and enhanced, it looks like it has a broad-based component to it. Also, less likely, I think, a meningioma.
Mm-hmm. So abscesses are usually like rim enhancing rather than like homogeneously enhancing. I mean, it's definitely on the differential. One thing that could lead you towards lymphoma, besides the restricted diffusion, is also she has autoimmune encephalitis, so she's probably on immunosuppression for that. And people who are immunosuppressed are predisposed to lymphoma. So we always think of HIV and lymphoma, but really anybody who's on an anti immunosuppression drug can be predisposed to lymphoma. And then MET, you could think about, it doesn't exactly look like a MET, but just because people with autoimmune encephalitis often have a history of systemic cancer. So this patient underwent a stereotactic needle biopsy, I guess because they thought this was pretty diffusion restrictive, so they just did a needle biopsy.
Yeah, that autoimmune encephalitis could also be called paraneoplastic limbic encephalitis, obviously known to be associated with systemic tumors such as ovarian dysgerminomas, testicular germ cell tumors, and others. And lymphoma is, of course, one of them, but systemic typically, not CNS. So that is an interesting situation. So this is a very pretty looking intraoperative touch prep showing very characteristic lymphoid cells and abundance of, large lymphoid nuclei. So it was an easier diagnosis on our part, saying this is going to be a lymphoma. Okay, you can see apoptosis, tiny little dark cells, and a lot of viable nuclei with characteristic chromatin pattern. Next. So on the tissue, if you remember what you were showing earlier on primary CNS lymphoma, there is a perivascular conglomerate of cells on the left side of the slide. So that is the perivascular typical distribution of the lymphoma cells. On the right side of the slide, you see the diffuse infiltration in the brain. Okay, next. Here you go again. This is paraffin embedded tissue as opposed to the intraoperative touch prep, which was fresh tissue. You see the same thing, an abundance of large atypical lymphoid cells. And on the right side, extreme right side of the slide towards the bottom, you see a lot of apoptosis. So there's a high turnover of these cells. somewhat prominent nucleoli. Next. And again, it was decisively diffusely positive with this membrane protein CD20, which makes this a B-cell lymphoma. So this is diffuse large B-cell lymphoma. They said this was non-germinal center immunophenotype and expresses BCL2 and c-MYC. So it may be a poor prognosis type of or subtype of diffuse large B-cell lymphoma.
Yeah, CNS diffuse large B-cell non-germinal center type. So since we already discussed lymphoma, I wanted to also talk about autoimmune encephalitis because it's another rare condition. It's not necessarily, or it isn't a neurosurgical disease, but it's sort of a neurosurgical mimic. I mean, I can envision somebody sees an enhancing mesial temporal lobe and thinks it's a glioma or something, and then does a resection, even though it obviously shouldn't be operated on. So it's important to be aware of it. So autoimmune encephalitis is a family of closely related disease processes that share overlapping clinical features and neuroimaging findings, but are ultimately differentiated by the specific antibody subtypes driving the underlying immune-mediated attack on different CNS structures. And despite its growing recognition as a rare cause of altered mental status, autoimmune encephalitis remains a diagnosis of exclusion. So whenever I guess when you're doing a workup of autoimmune encephalitis, there's two very important things you have to do. So the first is because the temporal lobe is involved, it's very important to rule out HSV. HSV can be fatal and is also treatable, so you definitely want to rule it out. And then also these patients often, not always, but often have a systemic cancer, so you want to do a cancer workup that can include CT chest abdomen pelvis, testicular ultrasound, because they can be associated with testicular cancers. Opto consult, you could have eye-related malignancies. So you want to rule out HSV and systemic tumors. They have multiple different antibody associations. This patient had CV2, which is the same as CRMP5, which is associated with small cell lung cancer and thymoma. So small cell lung cancer is, a common association, but other subtypes can be associated with testicular cancer, breast cancer, ovarian cancer, ovarian teratoma, thymoma, and it is possible to not be associated with a systemic cancer, other diseases, and they can have a ranging prognosis. This lady's CRMP5 unfortunately has a poor response to treatment. So that's it. I mean, you want to do a lumbar puncture to check for these autoimmune encephalitis antibodies. You probably have neurology is going to be on board with this. And then the other thing is they may have some T2 intensity, but it probably won't be the gyrus won't be as thickened as it would be with the glioma. And that's it.
Beautiful. Thank you very much.
Yeah, thanks so much, Dr. Goldtigan. We really appreciate it.
Alan, you want to take a coffee break or should we just roll into it? See there? Okay, all right. Can you guys hear me?
Yes, Doctor, loud and clear.
Okay, excellent, great. Thank you for having me speak again at Gand Rounds, Howard. It's always a pleasure trying to put these talks together. I just wanted to start out by thanking my partners, and obviously Barth and Roberto hired me 13 years ago, and now Alan and Jacques are leading the department, and it is really a fantastic place to work. This is a very, very special place. We're surrounded by wonderful residents, fellows, and nurse practitioners. I see some of them on right now, like Ruth, and It's really a pleasure to work here. So I thought a lot about what I would speak about for an hour, and I was putting together this talk about aspiring to be second. And I've been working on it for a couple of years, but I thought for an election year, it might be just a little too polarizing. So I thought I'd stick to something a little more straightforward like robots. So with your permission, I'm going to share my screen. And, you know, I have entitled this talk, Robots Are Only the Beginning, because I kind of feel like, you know, it's one of these type things that, you know, we're just at the cusp of this. And I know that many people feel strongly about robots. So I'm going to try to address a lot of different areas in this arena. So, and I apologize if some of the videos don't run so well, because now we're stuck in this crazy era. This is me and Marge zooming and just falling asleep. And of course, all of us are now experts at this. And probably half the people right now on Grand Rounds are not even listening to this and are asleep at home, and they just turned on their non-video sharing. And we know that that's the case. But that's okay, because it allows us actually to reach more people. And I think Jacques should be congratulated for running these giant Zooms with thousands of neurosurgeons all around the world. So it's really been a flattening effect on the earth. So it's got pros and cons in terms of what it's changed for us. And I think the same can be said for robots. So here's my disclosure slide. And this is important because, you know, this is about compliance and conflict of interest. But I'm going to show you a more important disclosure slide, which is I do surgery, and so do all of you, and we're paid for that. And I believe that in the right patient, surgery works. I want my patients to do well. I want to maximize efficiency and reduce complications. I think the current state of spine surgery, and this would apply to all of neurosurgery, is in desperate need of improvement. And it's not easy to make things better. So I think we have to rely heavily on technology. And we saw some wonderful lectures from Dan Yosher and Ian Kajigas 2 weeks ago talking about just how that might be possible with technology. Jacques, I'm sorry. I think you, yeah, there. Thank you. So this is this. I can't remember who sent me this. I want to say it was Shelby. This is a picture of obviously Greg Basil sleeping with the spine, and I tell the residents and fellows, you need to be dreaming about what you do, otherwise you don't care. And this is really the kind of passion I would hope that all the trainees are going to bring to this. I understand that that's not always the case, and that's unfortunate. But I think that this picture really exemplifies the level of passion that's needed in sort of a comical way to do what we do. And once you get to that level, you start to realize how deficient we really are. So here's a basic principle. Knowing where you are is critical. Anybody who's listened to the Dr. Death podcast about Christopher Dunch, who listens to it carefully, will think probably what I thought, which is this is a person who didn't know where he was. If you think about it, this is a guy who couldn't drive to work. How can that person be a neurosurgeon? I always like to say to the residents, I'd like to take the applicants out to eat and see how you eat a pigeon or a quail, and see how you handle your hands. Like I saw a resident eating with his hands the other day, and I know it was cultural, but it kind of grossed me out. It was like, you don't know how to use the fine motor function of your hand, and knowing where you are is a similar kind of thing. So knowing where you are in the body or in space is critical. So you think back in history, the Chinese invented the first magnetic compass, which changed everything because it allowed you to see where you were in direction on the earth. And then people started to use the stars, using a sextant, for example, to look into the sky to try to get an idea of where you might be to navigate the oceans. And then, of course, the geosynchronous orbit of all of these satellites that allowed for modern GPS systems. And that started in the 1980s, right? Which then, of course, led to programs like Waze, which was developed by an Israeli company after the Loma Prieta earthquake in California to get traffic around the I-5 freeway through the Newhall Pass. And then on to things like the self-driving car, right? This is a general principle of being aware at a granular and temporal level. Meaning granular, meaning exactly where, 1 millimeter, a micrometer, or a meter, or a mile, and temporally, meaning this year, every minute, every second, every nanosecond, to be able to accomplish tasks. So if you don't know where you are, you cannot perform surgery, just like Christopher Dunch. Remember, we're changing people's bodies, hence the emphasis on anatomic knowledge, right? But of course, anatomy is not always so stereotyped, right? and the ability for enhanced visualization, right? And I always tell people that if I see a surgeon who's just inordinately slow, like 2 standard deviations outside the norm, they're usually lost. It's not that they don't have any hands, it's that they don't know where they are in the body, right? So these are some of the robots at the CNS meeting in 2018. I counted a total of, I think, 11 robots, all of different types and varieties. And I'm not trying to pick any sides, but I will say this. If Timmer is successful in getting us the Excelsius robot, which is the Globus robot, then we will be the only center in the world with all 3 neurosurgical, or I should say all 3 spine robots, right? And so robots are coming about to be very important, and people have said that this is becoming the decade of the robot in neurosurgery, right? But let's just address some of the concerns in not the room, but in the space that we're in now, which is that a lot of people are afraid of robots, right? Well, robots can kill people. AI, computer-assisted driving devices. This is on the left. This is a Uber driver who ran over a woman in Arizona. It was the first, Tesla related death. Uber related death on the left, and the person wasn't watching the road, and the self-driving car hit a woman and killed her on the side of the road. She was crossing the road, right? I don't know if it's her fault or not, but I don't know that a human would have done better. And on the right is something that happened in northern Florida near Gainesville, which was a gentleman was in his new Tesla. Everybody loves the Tesla, right? And was on the auto drive mode watching Game of Thrones and went underneath a semi truck and was decapitated and killed instantaneously, right? So now, does this mean that these are bad devices? No, because you could make the argument that more deaths occur through normal driving and distracted driving or drunk driving or just random mistakes than could ever happen if we had self-driving cars. So, but people will point to these cases as being important. People say, well, one day we're going to get to the age where a robot kills a human, right? Well, that's why you got to read, because it's already happened, right? Here's the 737 MAX. This is the Ethiopia airplane. There's a lot of litigation over how this happened. There are 2 major 737 MAXs that crashed, right? Some say it was the lack of pilot training. The pilots interface to the plane, that they didn't know what they were doing, and that's what crashed a plane. Other people said it was a software programming error. And this is where I would push back a little about the root cause analysis type stuff, which is you can always look back and blame something, right? The reality is there was a change in the technology, in the way airplanes are flown, and accidents resulted. And it's really, I have a lot of Boeing stock. It's really destroyed their business model. And now COVID has been the second thing that's really hurt them badly. But you think about what that means when you introduce new technology. And then people say, well, robots might kill people someday. Well, guess what? It happened in 1979. Okay, so this is a young, unfortunate gentleman, Robert Williams, who was at the Ford casting plant making cars in Milwaukee, Wisconsin, and the robot crushed him and killed him. Okay, so people are like, well, one day the robot's going to kill a human. It happened 40 years ago. Okay, so people often, if you're just basically in your Facebook news feed, you're not going to really understand the world, right? You've got to understand what's really happening. And of course, the modern industrial robots have measures that try to prevent this sort of accidental interference with the human, right? Interference with us, right? And that's why when you use the Mazor X, there's all these steps to scan the space and do all these things. The FDA puts the regulations in place. And then people are like, well, maybe, those Boston Dynamics dogs that are so scary, like on Black Mirror, that are running around killing people, right? That's really going to be bad. And one day humans are going to use the robot to actively, consciously kill a human. Guess what? It already happened. Okay, I'm not talking about drones. This happened in 2016. Okay, this was one, and I don't want to get political about this, but there was a situation in Dallas, Texas, where a former military man was a sniper and hunkered down into a building and killed a number of police officers. I don't know if you remember this, but he was down in a sort of entrenched position inside a building, just sniping police officers, killing them off, just killing them, right? And I'll never forget watching this on the news. I was like, oh my God, they're never going to get this guy because he's gonna run out of ammunition first, right? So what did they do? Okay, this is really a sentinel event in history. The police were so desperate because it was hours of trying to get this guy, right? They took their bomb robot, the robot that they send into like take care of the bomb so no human has to put their hand near it. They took it and they strapped a bomb to it. And they said, we're going to send you some food. And they basically brought the robot close enough to him and they exploded the bomb and they killed him. So in the United States of America, we have already had a civilian use of a robot to kill a human, right? So I'll never forget hearing Steve Wozniak at the CNS meeting interviewing and being interviewed by, I think it was Russ Lonser, and they were, they do this sort of on stage interview and is asking, Woz, who actually invented all the stuff in Apple, not Steve Jobs, what do you think about like our relationship with AI and all that? And Steve Wozniak said something that just blew my mind. He said, we need to have like a Bill of Rights right now, before robots are more powerful than us. We need to have a Bill of Rights that says that humans can't harm a robot, right? It's always been the other way around. The robot cannot, prime directive cannot harm a human. No. That's a asymmetric discussion. We have a discussion that, we lay down in law that we can't harm a robot, and then maybe the robots will take pity on us. So this is sort of the backlog of fears and all the concerns that people might have about robots. So I'm going to dispense with all of that and move on to what we're doing today, which is spinal surgery in general. And I know that the brain surgeons use a robot too. And we have a Rosa here. I won't talk about that because I really don't know much about it. It can also be used for the spine, by the way. So that's a picture of John Adler. He was one of my mentors at Stanford University. John is a genius. He's been on our podcast. He invented the cyberknife. The cyberknife was invented by neurosurgeons. And it was invented because John was watching people on the bridges of San Francisco, Golden Gate Bridge, the Bay Bridge, using a backpack-mounted X-ray machine to scan the bridge for its integrity, to monitor, right? Is the bridge structurally safe for all these cars that go over it or not? And he said, wow, what if I could just put that on an industrial robot like the kind they use for automobiles? And he invented the cyberknife. If you don't understand the cyberknife, please go do that, because the cyberknife, which was invented in the 1990s, absolutely is the only robot that is truly free functioning, meaning all you got to do is push the button and the robot does the work that you've planned. There's no other robot like that in surgery. But, we talk about robots, and the reality is most of what we're talking about really are cobots. That is that an assistive device. It's not really doing the surgery. It's helping you do the operation. It doesn't do the operation on its own like the cyberknife does, right? So this is a picture of our team with the Mazor X Stealth Edition. We got one of the first 17 in the world here. We had the Renaissance, which is a smaller and earlier version, and Mazor teamed up with Medtronic to do this, and we've really had a good experience with it. Jason Leonakis, I'm going to give a shout out to him, has done a lot of work with research onto the robots. So a couple basic things. This is more like your typical talk. Robot enhances accuracy and efficiency. There's no question about that. I'm not saying the robot's better than you. I'm saying that it enhances accuracy and efficiency. If you look at all the meta-analyses, all the papers that are written, this is one by Paul Park in a neurosurgical focus issue, which I edited on robots back in 2017. You'll see that the accuracy rates in the high 90s with a couple outliers, definitely better than typical humans. Typical humans just putting in pedicle screws using fluoro, and even with navigation, it's better than that in general because it's just more precise. Now the robot can have big errors as well, so it's not 100% accurate, but it is very accurate in a big sense. And if you think about it, do you need it for every case? Well, here's two cases where there's a great deal of difference in terms of maybe the difficulty in cannulating pedicle screws. And you can see that difference might lead to your desire to want to use a higher level of technology in certain cases, because the amount of radiation exposure or O-arm spins you need to get the screws placed properly might be harder on the case on the right. How about facet violations? This is a very important space because you think about how violating the proximal facet can lead to adjacent level disease. That's becoming more and more well proven. And if you look at this is a forest plot showing favoring robot on the left side of the line, and on the right side being freehand surgery, that the robot is better at avoiding the proximal facet because you plan it in 3 dimensions rather than just trying to get a safe pedicle screw in, which is the typical type of surgery we do in the operating room. So you can see that. But there's another bigger piece, I think, than that, because a lot of folks will say, well, that's not enough. I'm a master surgeon, Mike. I don't need the robot. I'm really good. I've done 10,000, 20,000, 30,000 pedicle screws. Doesn't really matter to me. Well, let's think about occupational hazards. Occupational hazards, I spoke about 8 years ago at Grand Rounds. Very important space. I try to lecture in the OR about this because the young residents have no idea what's coming to them. You get to my age, you start to feel the effects of thousands of surgeries. How about radiation exposure? Okay, this is an important area. Some people are terrified of radiation exposure. I think it's obvious. And here's a shout out to Timur, one of our new faculty members who trained with us. Timur does some amazing work with augmented reality, trying to minimize the amount of fluoroscopy that we use in the operating room. We are very liberal with fluoroscopy here. We probably use more radiation than any place I've ever heard of, which is not neither here nor there, but it's important to realize that a lot of folks are very afraid of radiation, particularly in East Asia. Timur's technology that he takes off the shelf has been used further. This is the type of, he's got, I think, 3 or 4 different kinds of glasses. He can chime in at any point. But here we have just hooked it up to the fluoro machine for surgery, and he's been looking at x-rays with this. And I'm just going to show you a picture here. On the left, you'll see Jason Leonakis. On the right, you'll see Timur Yurikov. They're both doing endoscopic surgery. And you can see them in 2 planes, one looking across the table and one looking from the anesthesia perspective. And on the left, you'll see Jason is turning his head to look at the screen because he's got to have the fluoro machine over here and the viewer for the endoscope over here. And you can see here on the right, Timur is assuming a much more ergonomic position. And I think Timur's published on this in terms of ergonomics in general with surgery when he attached a positioning device on his thoracic spine. And I think he published that in World Neurosurgery. So it's really important to start thinking about the ergonomics of how you do surgery. How about this? This is a spine exoskeleton that is now being used in the automotive industry. So this worker here has to work underneath the car in the assembly plant all day long. So 8 hours a day with maybe a couple breaks, putting his arms up over his head, applying force, drilling, putting screws in, whatever it might be. And you can see that Exobionics has built for them an exoskeleton, right? And this becomes kind of like in the movie Aliens with Ripley using the forklift, right? That this really allows you to do things better and easier with less fatigue, right? And you think about that, that's quite an important thing in long surgeries or just in the course of a long career of multiple decades. What about how we deal with cases, how we discuss cases? You say, well, how does a robot change anything about that? It completely changes it. The planning software forces us to consider geometries and elements of anatomy that maybe might not have been considered before surgery, right? So when you think about incredibly complex surgeries, right, you wonder, have you really planned this out? And I'll never forget, Steve Andra came out to USC as visiting professor, and Steve was in the Navy. He ran the VA for a while, and he's a little bit of a controversial figure now, but Steve, he ran things like a quartermaster in the military. He would put up on the board, instead of just the glove size, all of the levels of the spine, the screw lengths, sizes, and all that, which would go first, where he compress, where he distract, all those things. And then, that was really a way to think about things in the right way. And Dave Pauly on our podcast last month talked about how, they'll set a time on that whiteboard. They'll put, we're going to finish the surgery at 12:30. And they'll be held accountable to that. They'll say that to everybody. And if they don't make that mark, it'll be like, okay, well, you're just lying to us now, right? And so you start to think about, well, how you plan a surgery. I mean, how many people actually do this? I know you guys look at the films. I know you think about what I'm going to do, but do you plan out the detail of what I'm going to do, what the steps are going to be? And I'm going to come back to this in just a little bit. Now, this is the Mazor X with Stealth Edition. You can see what we're doing here is this is me manipulating the robot, and you can see there's this concept of hysteresis and all of this stuff that in terms of what we can do and what the rigidity, if you will, of the system, right? And so here's another video showing how we put a screw in with Stealth Edition. So you can see live navigation with Stealth, robot assistance, and we are going to utilize the hysteresis of the system. That is the ability to move it a bit to get targeting and safe trajectory. So some people have favored an extremely rigid system. Some people like a little bit of slop in it. I can tell you that the extremely rigid systems have their own problems, and that can be an offline conversation, if you will. Gets quite wonky in terms of why that might be the case. So one of the ways I look at this is that the robot can allow a surgeon to do surgeries they might otherwise find difficult or even impossible, which is that, look, we all wish we could be, Ghazi Yazragil, right? Or Jürgen Harms, but not everybody can be that person. And maybe you have other qualities that are better besides just technical skill, right? Or maybe you're just in training. So I'm going to draw your attention to a paper that Shelby, Timmer, and Ken and I wrote years ago, which is our academic experience with the Mazor Renaissance, right? And this is really, I think, I'm going to be self-serving if I say this, but it's true, one of the most important papers that is out there about robotics, because everybody understands the accuracy has been proven. So this shows the experience level or committedness of the surgeons, right? So if you look at the top graph here, this figure just shows you that if you look at the junior, if you will, residents, PGY 1 to 5 versus PGY 6 to 8, this is the speed of screw placement, okay? The experienced guys are just a touch faster, just a little bit, right? And then if you look here on the right, this is experience using the robot, right? So if you've done a couple cases versus more than a couple cases, you get a little bit faster, right? But the learning curve is I don't even want to say it's steep. It doesn't exist, right? It's not like that. You don't need a lot of experience, fortunately, to get good at this, right? And then whether you're dedicated to spine, so let's say we take Dan Eichberg, who's done just a handful of spine cases, but is great at cranial. He's not dedicated. He's a little bit slower, right? But not much in terms of screw placement. And I'll never forget, I was at the spine safety meeting talking about this, and some really ancient orthopedic spine surgeon whose daughter was an orthopedic spine surgeon came raised his hand and said, Mike, where's the virtue in that? You're showing that it doesn't take much to train people to put in pedicle screws. I trained for years to do this, and now you're saying you don't need training for it. So I am going to take objection to that, right? You know what? There is a lot of virtue in sacrificing yourself to learn how to put in pedicle screws, and you need that skill. But it doesn't mean that you should forego good technology. You think about the bicycle or the horse or the car. So yeah, who's the best athlete in the group? Probably Shelby, right? Shelby can outrun me probably by 30 miles. I can run about a quarter mile. He can run 30 miles. Guess what? I got a car. Too bad, right? So think about it from a different perspective, right? It's not just about chest thumping. It's about what you can do. Now you're freed up to think about your osteotomies. You're freed up to think about your planning, freed up to think about what's right for the patient, how to take care of them, not just putting a screw into a pedicle, right? So to that end, this is a dated slide from 2015, but I love it. I don't want to pull in too many residents into this kind of thing, but this is John Sarak. He graduated a number of years ago. He was super committed to spine to the degree the cranial guys wouldn't talk to him, right? John was a 7th year chief resident. He'd done over 500 spine surgeries. He's from Missouri. He's got 2 dogs. He's married. IQ's pretty high. And over here's Greg Basil. This is when Greg was an intern, and Greg was an intern at the time. He'd done less than 10 spine surgeries. He worked at BlackRock. He was single at the time. Now he's married to Christina, who's wonderful. And his IQ's, roughly like John's. John hated the robot. He really hated it, right? Because he had spent 7 long years learning how to put in screws, right? And Greg loved the robot then. Now, I don't know how Greg feels now, right? He's cut his teeth. But this just shows you how your perspective might change when you're in training versus when you're a little bit older. So I always think about this legend about Paul Bunyan and his blue ox babe. This is a Minnesota thing, when Minnesota was the West, when America was settling the West. Minnesota's the Midwest now, but it was the West then, and they had to clear the land, right, to live on. And Paul Bunyan was a giant. He stood like 30 feet high. He could cleave like 10 trees with one swipe of the axe, and his ox babe would haul the lumber to the cities, right, to Chicago and New York and New Jersey and upstate New York. And there's a great Disney cartoon showing this competition, this wager between Paul Bunyan and the inventor of the chainsaw. And the reality is Paul Bunyan is a superhero. We as neurosurgeons aspire to be that superhero, right? But the reality is that doesn't allow scalability. And scalability is what really will win the future. So let's take, for example, our Wake Fusion project. This has really been, it's not perfect. No question, it's not perfect, right? Not everybody does great with this. It's not for everybody. There's limitations. I got it. But there is no question, if I went to Walmart or any institutional stakeholder, right? Mike Wang with Wake Fusion versus somebody else with a standard or MIS fusion, I'm going to win. I'm going to win on almost every metric, okay? Doesn't mean I'm doing things better. I'm just saying that from a cost, time, resource, complications perspective, I'm going to win every time, right? Because it's different. But I can't really teach it easily because people are like, well, you got to do it without general anesthesia. I'm afraid of that. Oh, I don't have BMP in my hospital, et cetera, et cetera, et cetera, right? All the excuses come out, right? But the reality is that if I can't scale it, then nobody's going to do this stuff, right? So what if I were to take this awake piece, which is the part that scares people the most, just take it out of the mix and instead replace it with the robot, okay? And I'm not saying they're equivalent. I'm just saying, for sake of argument. And then I get accuracy and localization with the robot. I get stabilization with like perfect fixation. I get pain control with the expiral. I get distraction and correction with interbody. I got arthrodesis with the BMP, and I get miniaturization with the endoscope, right? So Jason, again, helped me out with this. And I apologize if the videos don't run, if your internet's a little bit low in speed or bandwidth. So this is just us showing how we do the robotic fusion. And this is no longer awake. So the patient's not moving or anything like that, because we don't want them to move when they're pinned to the robot, right? So the robot here is doing its scanning piece. And that was the part I was telling you about, to make sure the robot doesn't hit anything or anybody. Now, this robot's not going to kill anybody, but the point is it doesn't want to hurt or hit anything. It's an FDA requirement. And then we're going to do all of our localization with the robot. So now you've taken all of the features that make me special, right, in terms of technique, and you erase it. And you say, look, we could take Mike Silva. Mike's probably done 1 or 2 spine surgeries in his life, and we can probably teach him with a little bit of instruction on how to get through these steps and have a safety level of something like 95+%, which is as good as any decent spine surgeon, right? And I'm not saying that it's equal to having experience. That is not what I'm saying. What I'm saying is the technical elements of how you do this. Think about Gamma Knife now. Damian Brusco rounded with me this morning. He was doing a Gamma Knife. It's so easy now, right? There was a time when Gamma Knife was very complicated. There's a time when it took a lot of work and a lot of thinking and a lot of planning to do that stuff. But the fact that you can scale it, the fact that you can show people how to do this, that you can do these steps without having to worry about what's going on. Let me give you another example. People worry about this. They're like, well, so you're saying that you don't need any experience. Well, let's take the other extreme. Let's say that I'm now 60 years old and I have done, 11,000, 15,000 spine surgeries. So I'm a master, right? But I developed Parkinson's disease. Okay. And I have all the knowledge stored in my brain, right? Better than any resident, better than any fellow, better than any junior faculty member. But my hands shake. Okay. And they don't now, but they might in the future. Shouldn't I still be able to do surgery? Well, if you rely on your hands being absolutely stable, yes. But if the robot can take care of that element of it for you, then you get to leverage your brain, right? So this is the kind of thing that I'm talking about in terms of what the future means for extending the lifetime of experience and wisdom, as well as the other end of the curve, which is into early training, right? So what's coming next? So I said, robots are just the beginning, but I've shown you only the beginning, right? I haven't shown you anything else. So let's talk about what's coming next, right? So there's a lot of stuff coming. But remember this is one of my favorite 2 quotes by George Bernard Shaw. The reasonable man adapts himself to the world. The unreasonable one persists to adapt the world to himself. Therefore, all progress depends on the unreasonable man. Okay, now think about that for a second, right? Because it's a big statement. It's a big, big, big statement because everybody is telling you to be reasonable all day long. And if you watch, I miss Karthik because Karthik's graduated after 11 years or something like that. But Karthik was such a devotee of Steve Jobs. It was almost like a pathology, right? And I love that about him because he recognized that in Steve Jobs was this kernel of genius and unrelenting drive for perfection and a flawed human, right? But this is what George Bernard Shaw is saying, is that if you just say, yeah, okay, well, yeah, do it like everybody else. Yeah, this is fine. I'm just going to make my hay and, just follow along with others, right? That is not progress. Right? That is standing on the shoulders of Barth Green and Roberto Harros and the giants that came before you to just say, I'm just going to keep doing it. And then somebody like me, some jerk like me is going to come and outcompete you and put you out of business, right? So here's what robots are good at. Robots are good at a lot of things we're not good at, like knowing your position in free space, repetitive tasks, maintaining constant positions endlessly, micromaneuvers, controlled force application, not being confined by biology, meaning their biology or anatomy, not the humans, but the operators. Humans are good at least for now, decision-making, identifying visual landmarks, communication, adapting to unusual architectures like how the room is laid out, adapting to changes and switching between modes, methods, and techniques, right? So we're good at that piece. So here's Michael DeBakey. This was at the Suns meeting. Jacques and I were at the Suns meeting years ago at Houston. And one of Michael DeBakey's partners, if you don't know Michael DeBakey, you should look him up too. Michael DeBakey was an absolutely phenomenal and difficult person, just like Steve Jobs. But this surgeon didn't really like Michael DeBakey, even though he was junior partner to him. And I love this because Michael DeBakey's like saying, you know, get an EEG to see if this resident has any sign of brain activity, right? This is a just DeBakey quote. And here's another one, right? If I had 3 hands, I wouldn't need you at all, okay? Well, what if you had 3 hands? So here's a picture of the Da Vinci robot, which most patients think is the robot, right? Assembling a sandwich. Why are we confined by 2 hands, 2 arms, 10 fingers, 2 legs, and hands of a certain type? The robot can be built any way you want it to be built. It is not necessarily anthropomorphic. But the current robots we have, admittedly, are very limited. They essentially are trajectory stabilizing and providing machines. So they're very, very limited. Now, if I were to take a standard surgery like a MIST lift, and I were to show you these are, you know, I know there's many steps, but let's just lay out these 9 steps, right? If I said, well, what does the robot help with? Okay, well, it doesn't position the patient, although you could have a robot for that. It could help plan the incision. It could help that, right? It doesn't dissect planes. It doesn't place retractors. It doesn't do decompression. It doesn't do disc prep. It doesn't place cages. It does place screws with your help, and it doesn't help with the rod. So 2 of 9 essential steps are performed by the robot. So most surgeons go, well, deal breaker, $1 million capital equipment, not interested, right? So what's next? So here's an example of the Mako. This robot exists today. This is for hemiarthroplasty in the knee. And what they're doing is they're trying to standardize the knee surgery. They're trying to standardize the preparation site for the hemiarthroplasty implant. There are over 1,000 Mako robots in America. Now, this can be a whole grand rounds about Mako knee and whether we need a Mako or not. And it's very, very long and extensive, but there are 1,000 of these robots out there right now, and it provides haptic feel. So what it does is you can see this surgeon seems to, I mean, I'll be honest, I don't think I'd let him operate on my spine, but it confines him. It has haptic feel. So you say, okay, lay out this part of the bone. We're going to drill this area, and the robot will keep you in the confines. All you got to do is go like this, right? It's like paint by numbers, right? Paint by numbers surgery. I hate to say it like that, but it's true. And that is super powerful because now you're talking about limited bone removal and control. This is a device in Germany. So using AI, okay, to drill through an eggshell. So the residents, Jacques can comment on this, but residents don't go to the Midas Rex course anymore. But this robot, if you will, measures the pressure on the drill tip, so you never go through and puncture the membrane of the egg, okay? Well, temporal bone drilling, right? There you go. Now you can monitor that, and you can have a safety margin in terms of not drilling into the wrong area. Here's a robot for hair transplant. Okay, dermatologists are very good at Jeremy, Barth Green's son, is a fantastic dermatologist, one of the best, and they rely heavily on looking at things and visual orientation and diagnosis. But hair transplant is like this. It's showing you where things can be. Like, in other words, we need to put a hair plug here, 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 and here. And that robot is basically an optical sensor, then automated, like almost like a textile robot, placing the implants, right? And what about sewing? Well, this exists already. This is a robot for sewing up a valve, heart valves, because speed on sewing in cardiac surgery is absolutely critical because that's pump time, right? That's pump time. So you think about all those pieces, and let's say we were to implement those types of robots, and we still don't have the position. Actually, we probably need the positioning robot the most, right? Because there's the occupational hazard to the MSAs and the nurses. But you can plan the incision. Can't dissect the muscle yet, right? Can't doctor retractor, but you can do the facetectomy and decompression. And you can do the disc removal and the fusion preparation. And you can maybe place the cage, but probably not yet. And you can do the screws, but you can't place the rod. So if you look at the next generation of Mazor X, there is a robot rod bender attached to it. So you just say, I want the rod to look like this. This is how the screws went in. And it bends the rod perfectly for you because it understands the 3-dimensional anatomy of the screws and whatnot. So this also relates to the human. It's not just about the robot, which is this concept of practice and rehearsal. I'll go back to that picture of Greg Basil sleeping with the spine model. You know, it really annoys me, and the residents know this, when people just show up in the OR and they think they know what they're doing. I mean, we're actually doing really complicated stuff that's risky and fraught with problems, and we still have issues. Yet, I'll bet you guys spend more time training for softball or the Olympics than you do for your surgery the next day. And to me, that's not good. To me, these things that we see, musical performance, dance, athletics, is fun and superfluous. Surgery is essential, okay? So why don't people practice and rehearse for surgery? Isn't that funny why we don't do that and how we don't do that? This is a movie clip from, if it'll run, from a Japanese soap opera, maybe it won't run, showing it's an opening sequence of the movie showing, it's about a cardiac surgeon. And my dad told me about this show. It's like a soap opera, like a Grey's Anatomy. It shows the surgeon practicing before he scrubs in the morning, like he's getting into the right mindset. And I think that that's what we should be doing, just like with martial arts. But it's more than just that. It's more than just the physicality of what we do. The ability to think ahead and plan ahead is one of the things that distinguishes us from animals, from lesser mammals. So this is a very interesting concept, which is imagining the future, right, is another form of memory, okay? And think about what you're doing when you're planning a complex case, is you're imagining the future, and the concept of dreaming. And this has come about in anthropology, this idea that dreaming is essential for human survival. I can tell you, I dream all the time about spine. I usually get my best ideas about talks and product development in the morning when I wake up, because I've spent the whole night dreaming, even subconsciously, about these ideas. And you think about one of my favorite movies, Leonardo DiCaprio in Inception. I mean, that movie really blows your mind in terms of what that really means. And why do they think dreams are essential for survival? Because in a dream, you can play out what happens. You're being chased by hyenas. What do you do? Oh my God, I ran into this way and that. And you play it out in your mind, in the dream. And then the next time that happens, maybe you have a better idea of how to handle that. And I'm not just saying this in an abstract sense, because the robot does that, okay? Here's an example. This is us playing with actually Chris Barbario playing with the robot, and he is planning screws live. We haven't put any screws in. He's playing around with it, saying, let's try it like this, let's try it like that, without execution. So you separate the planning and the execution, you get a plan visually, and then the execution happens seamlessly, because that's the other part of practice, is that you planned it, but your execution sucked, right? So the robot handles both sides of that, which is it encourages you to plan properly. It encourages you to experiment with different things that might not work. Then you settle on your plan, and then it helps you execute your plan seamlessly. And that's very important. And I think about one of my heroes, Chris Kyle, American Sniper. I have all of his books, American Gun, American Sniper. Chris Kyle was a real patriot. And I know it's controversial if you're from the Islamic world, but the point of the matter is that he was a master sniper. He was so good at this. He claims to have had the most kills in American U.S. military history, right? But there's another device that John Jagged knows about, and this is the TrackPoint X. This is a $23,000 sniper rifle. It's attached to computers and sensors that allows any idiot like me to hit a plate, a 12-inch plate at 1,000 yards, because it calculates the wind and gravity and the rotation of the earth and things that at 1,000 yards of ballistics really come into play. I don't know how most people calculate the rotation of earth. I think it's experience, right? It's learning and training, firing tens of thousands of rounds, figuring out how things work. And TrackPoint X just takes care of that for you. And again, people go, well, where's the virtue in that? Well, I mean, I guess if you're trying to fight a war, the virtue is trying not to get killed. The virtue is trying to win the war and end it as quickly as possible. So here's another example in real time. This is in real life. This is MIS surgery, where how you put your screws in affects the rods. Just yesterday, we had a case where the screws were put in and the screws weren't pretty and the rod doesn't look pretty. And if it was done MIS, it would have been a very difficult connection Fortunately, it was open, and you can see you try to get the rods to be straight and lined up, not just for how they look, but how they pass, and you can make the correction to try to avoid those interference points, right? So what's coming next? Lots of stuff, okay? Real-time visual spectrum monitoring, okay? So right now the robot doesn't see anything, right? But it actually does. This is the Mazor X with Stealth Edition. This is what's sitting over at UMH right now. I'll draw your attention to the part of this that is out of focus back here, right back here, okay? Looks a little bit like Wall-E, doesn't it, right? Okay, this little device is watching us, okay? And it's not a privacy issue. People are like, oh, it's HIPAA. No, I'm talking about it's watching the robot. It's making sure there's nothing that's getting in the way of the robot. But in the future, you know what it's going to do? It's going to say, that's not a number 4 kerosene. Okay. Oh, you're about to drop your Penfield. It's actually visually monitoring what's going on. It was built this way. The Israelis are so smart. They built it this way because they know that the hardware needs to be built in ahead of time for the software on the back end. Improved sensing. Okay, this is really critical. As you get older, your senses get worse. But humans are limited to our 5, 6 senses, or maybe some of you have a 6th sense. Like Kat Berry says she has a 6th sense, right? Maybe, I believe it. Yeah, but 6 senses, right? But there's more than that. How about being able to detect through vibration and material density sensing, right? Using vibration to feel something and know what it is ahead of you. How about using tissue impedance? Pedicle screw stim was essentially invented here by Blair Calancy, Nate Lebow, and Barth Green that we use every day, right? How about combining sensory inputs? For example, photoacoustic imaging. It becomes limitless, right? Because we're limited to what we can see. In fact, you only have 2 eyes on the front of your head. You can't even see behind you, right? The robot can have 20 eyes, 30 eyes, 1,000,000 eyes. It doesn't have to be so limited like we are. Micro manipulation. Okay, so I use this for a talk about the bigger hand, the little hand. Everybody's like, the bigger hand's better. And I'm now always telling the residents, I don't know what it was. I don't know. It was maybe Steve's hands are big and he's so strong. But you know, everybody's wearing gloves that are too big for themselves, so the hands are slipping all over the place. But the robot hand can be 3 millimeters, or it could be 30 meters. It can be whatever you need it to be. 9 fingers, 6 fingers, 1 finger. You don't have to be so limited anymore with the robot. And think about energy and force control. So I don't know if these will run. I'm hoping these will run. This is Jacques Morcos. Okay. Okay, and this is an orthopedic guy. Okay, these are the ends of the dynamic range of human function. Jacques with a super precise millimeter level or sub-millimeter level movement. And on the right, you see this guy just whacking the hell out of his knee, trying to, I don't know what he's doing. I think he's explanting an IM nail or something like that. You look at the difference in dynamic range of the human, right? But that's the limit. In other words, this guy can't get any more force onto this object than this, right? He's exhausted. And Jacques can't get any more sub-millimeter than he is here on the left. That's the dynamic range. There's nothing else. But what about things besides physical force, right? What about using other techniques, right? What about using ultrasound, right? Now we're getting into some real X-Men stuff, right? What about using stuff like that? What about functioning in a certain small space? You saw how much momentum had to be built to deliver that force. What if you didn't need that space to do it, right? What about fatigability? This is a paper about ENT surgeons getting more fatigued as they're doing their surgery, getting weaker and weaker and less precise because they're getting tired. Robots don't get tired that way, right? So what about using these as adjuvants to what we do, right? So the robot right now, maybe in the near future, good at making the average surgeon better, allowing all surgeons to perform these complex or MIS surgeries maybe, micro manipulation, improved sensing in the future, minimizing our stress, and extending the lifespan of the surgeon, which is not to be, those people who are young don't care about this. Those people who are old care a lot about this piece. And I think about it like this, you know, Barth Green has been operating for, I don't want to overspeak, but I'm going to say something like going on 40 years, right? 30 plus years. And he's done, I'm guessing, you know, 15, 20,000 surgeries, something like that, right? He's like the Navy SEAL, right? He's got all those skill sets, right? He's done it all, right? The drone is like the robot. So the drone can do things that the human can't do. The drone can fly. It can stay in the air for days, right? And that's what the robot is like, right? The robot is a way to get us to be better, our better selves, our better surgeons, not to replace us. It's not going to happen like that. It's going to take a long time to just replace us. Think about it also from this perspective: disease progression and treatment. Patient comes in with a disease. Let's say it's a spondylolisthesis. Now we look at this, and all the 7 spine surgeons here would be like, well, I do it like this, I do it like that, I do it like this, I do it like that. We're just giving our opinion, right? But the big data and AI will tell us, well, this does need a fusion, this doesn't need a fusion, this needs an inner body, it doesn't need an inner body, it needs this kind of fixation. That's really critical. We don't even have that piece yet. Then you execute on the surgery with the use of robots. And then you tailor their recovery process. So I've been big on ERAS. Damian Brusco, as you know, has helped a lot with the ERAS program here in spine and now with brain. And this is the SNP gene. This is genotyping of people's sensitivities to narcotics and addiction potential. Wouldn't it be nice to know which patients are more likely to get addicted to narcotics genetically, right? Right now, I use age as a surrogate. That doesn't get deep enough. And then monitoring people over the progress afterwards. And we saw a great lecture from Greg Basil a couple months ago talking about using AI and smartphone technology to monitor people's progress and see what happens and see when they do worse. And then being able to trigger the right interventions or diagnostic modalities at the right time in the patient's lifespan to get that done. But remember, Ed Benzel says this: a fool with a tool is still a fool. You have to be very careful about what you use. MIS is notorious for this, that we're like, wow, here's a great percutaneous system. We're gonna percutaneously place this screw, drill a hole right through this bone. And because, we got this new tool, it's super cool, right? But the problem is there's a lot of important stuff behind there, like nerves, right? So these are really important elements that you have to think about in terms of what you're going to do with surgery. So I'm going to draw to a close here. If people have comments, I want to thank my partners for being so supportive, the residents and fellows for being amazing and working so hard every day. Please listen to the podcast. Many of you have been on. The listens have been amazing. Rick Komitar and Alan Levy and Jock Morcos have had just about 2,000 listens per episode now each. So thanks for doing that. And anybody who wants to be recorded for this, we just recorded Susie Orman last night, and we're about to record Jocko Willink. So we're getting into the big time. So please get in on the game before we get too big, okay? Take care, be safe out there, enjoy the day, and good luck with your surgeries.
Mike, hey, can you hear me?
Yes.
Fantastic, really good, really inspiring, particularly for the young who are far away from developing Parkinson like the rest of us, but great. You make excellent points. Bill Caldwell has a patent for a temporal bone drilling machine he's been working on for about 15 years, and it can do a translab in 5 minutes. As opposed to, I guess, 3.5 hours that the neuroautologists do. So clearly this master's kind of the smart slave relationship is great. But when do you think the next step is, which is, you alluded to it, but do you think many years before it can take over almost completely decision-making from us human surgeons? At least in the spine world.
Jacques, that is a great. So you're talking more about the knowledge side, the big data, right?
Yeah. Okay.
So those of you who hear me in the OR know that I really bristle at this medical rec EMR thing. It's not because I'm not good at it. It's because Epic in Madison, Wisconsin owns your data, and we pay them $100 million, and so does every hospital, to come in here and put in crappy software, and they're collecting all of our data. And when you're busy doing your little notes and prescribing all this stuff, it's checking on this and it owns that data. The good news is they're not very focused. They're like a kind of a crappy company trying to swallow the world. They were helped by Obama. Basically, it was Obamacare that injected $1 trillion into Epic. You go to Madison, Wisconsin, where my son goes to school, it's all Epic. All the flights in and out, it's all Epic nurses, right? Because the mandate to have EMR was it's like a Cylindra project. It was like basically an injection of $1 trillion to get one company to run ahead. Now, I get it if they're trying to compete with China, because China is actively doing this. I think the problem is that you know about the IBM Watson project, right, Jacques?
Yeah. Yes.
So just for the residents, the IBM Watson project was the idea after Big Blue beat Ken Jennings on Jeopardy and then beat the chess masters, right? They said, we're going to take over cancer care. So they fed Watson hundreds of thousands of oncology papers to try to get Watson, which is a robot, I'm sorry, an AI, right, to get so smart that it could say, okay, this cancer needs this treatment. We just heard neuropathology discussed for an hour. No, forget it. It's done. Rick Komatar's the what is it called? The pathology computer. I'm blanking on the name of it. Is going to get the diagnosis. Then Watson is going to tell you the chemotherapy to give. Okay. It failed. I don't know why it failed. I think that because just like maybe it's the humans are so bad at this that it gave so much bad information. But I think we're getting close because this concept of the doubling of knowledge or computer processing speed every 2 years is exponential. My guess is you're going to see the first iteration in 5 years. For 5 years, you're going to see the simple stuff like hip replacement. Okay, who needs a hip replacement? Okay, put in these variables. The AI machine learning has figured out you should or should not get it. And of course, that has a flip side, which is the rationing of care. This really gets a little scary. I think for neurosurgery, because we're so good at not giving people the data, every randomized controlled trial in the New England Journal says we shouldn't do surgery except for Don Becker's, right? We shouldn't be here. We none of us need to go to work today because what we do doesn't work, right, Jacques? Right. It's ridiculous. It's so ridiculous. And if you fed all the New England Journal papers into Watson, they would say, cancel neurosurgery except for trauma and only subdurals then, right? It's ridiculous. So we are privileged, and I think in some ways we should retain that Jedi master ability. The Jedis fought Count Dooku, right? That's the robot Sith, right? And the robot Sith is powerful because you can program a robot to almost be like a Jedi. I think, Jacques, what you do and what Bobby does and what Eric does and what Roberto did and everybody else in this faculty is so precious. It's not easy to replace. And so maybe we've got another 15 years for neurosurgery. That's my guess. 15 years until we're taken over by that. That's a long answer. I'm sorry about that.
That's okay. But it's interesting how, the robot like Frank Siventos at UMH and some of the other ENTs have been using the Da Vinci, I guess, for oral surgery stuff, but so do you think it's happening in neurosurgery now? Because there isn't probably much money in it. There are robotic things that you could do bypass with, but there isn't much money to miniaturize stuff that they did, for example, for coronary artery bypass. There's something called the Cardica device where they, the economics of it will get in the way as well.
I'll tell you, Jacques, I travel to China a lot, not since February, of course. And, I'm Chinese ethnically, but I bleed red, white, and blue. And so what really I think is going to happen is the secondary markets are going to beat us. You're right. America, it's all capital markets. We have innovation, but the Chinese are going to beat us to it. I've seen what they're doing. They can get the data. They have the patients. They can get the surgeons to do the same thing. They're standardized. That's my fear, is that the Chinese are going to beat us to the punch on this. So this is why I'm giving this talk, because I don't want them to. I want us to beat them at the punch, because I think we'll do a better job of it. You're right about the money piece, but the flip side of it is that venture capital is so powerful in this country that if they're sold properly on it, then they'll want to go there. And neurological disease is the growth area, right? Let's just say that I can envision a future where cardiac disease is conquered. It's not actually that hard to envision that, but neurological disease, not so easy. Yeah. So I think the future's super bright for us. I think we've got great job security.
I propose Mike Wang for president. If you haven't voted yet, when you go to the ballot box, please put in Mike Wang.
Too many skeletons.
Thanks, Mike.
Any other comments, questions? Oh, there's Barth. Barth, you're muted. You're muted, Barth.
You are muted, Barth.
I'm in the OR taking my Cinnamate. Thanks, Mike. That was wonderful.
Great. Okay. Well, if nobody else, then can I close it, Jacques? Is it okay if I close it out?
Sure. Thank
Okay.
you again.
You guys have a great day.
Bye.